Good morning, everybody. How is everybody going? You get your coffee, you're ready for round two. I've actually been in Michigan before. My largest project when I started my career was actually at the Michigan Employment Security Commission in Detroit. I understand for those of you in Detroit, Trolley Plaza still exists downtown. I spent a year there, so I'm glad to be back and actually enjoying my time here. Before I get started, let me ask a couple of questions so I kind of understand where each of you are as I go into some of the details. How many people here have been to either HIMSS 16 or HIMSS 15? Been to a HIMSS conference in the last couple of years? So about a third of you. How many have been to an HL7 meeting in the last 5 years? Actually been, all right, even more, half the group. Fantastic, glad to hear that. And last question, how many here were at day one of this event and got to see Halamka's keynote? All right, everybody, this is fantastic. That'll help a lot. I'm going to be really following up on a lot of the things that Damien and Wayne said, but giving it to you from the payer perspective. One of the things, though I work for Blue Cross Blue Shield Association and have been there 12 years as their voting representative for Health Level 7, I've also been active at Health Level 7 at some of the work groups. I've been a co-chair for one of the work groups, and I've also been active in a lot of industry initiatives. Since I've worked with Cigna, Optum, Aetna, and Humana, I'm going to be actually trying to represent the payer perspective today. So I'll be sharing quite a few Blue stories, but I'm not here officially for Blue Cross or for HL7, but just representing a payer SME that can share with you why we are kind of excited about FHIR. What I'm going to try to do today in about 20 minutes, so there'll be some time for questions, is define FHIR from our payer perspective, just elaborate on a couple of things in the FHIR definition, and really go back to what's driving the payer interest here, which would be value-based care. Some of the things that you heard from Dr. Halamka, some of the things you heard from Dr. DeSalvo, and some of the things from Dr. Geltzer. And then I also want to share the vantage point, though most of you have been at a HIMSS in HL7, there's some things I want to share that we've been seeing there that tie back to why FHIR is an interest from the payer perspective. And then let's talk about some of the use cases. I've been one of the folks that was involved in doing the planning for the HL7 payer summits. We've had 3 of them. The next one will be in January next year in San Antonio. Welcome to come. It's a really good place to visit, and the Riverwalk's a fantastic place for some good food. But there's some things the payer vendors have said. I want to share those with you for perspective. And then I'm going to do a deep dive for one of the Blue plans that have done something with FHIR and explain to you the details of the $500,000 they are saving from doing FHIR in 2016. So we'll get into that detail, but want to have that figure in your head for why payers are starting to get pretty excited about FHIR. And then I'll summarize the big picture. How does this tie to payers, providers, vendors in the healthcare ecosystem? And last but not least, I'm actually going to make sure you've got some action items that you can take back for you personally or with your organization. So let's get started on FHIR. What you're seeing in front of you, we're not going to try to go through the whole page, but Circle Square is a company that the association hires and gives us a monthly HIT trends report. So back in March, we asked them, well, give us your official read on FHIR. So the first column really talks about FHIR. The second is what's the difference it makes for interoperability. And the third is what vendors are actually doing with FHIR. In the first column, second bullet down talks about an important thing that each of those resources is tagged like a URL. And where that's valuable to payers is at the bottom of that first column. It means that I can have multiple applications in production find and use that same resource. So real high resource reusability is what we can do operationally. In the middle, talking about interoperability, one of the things that the HL7 standards that Damien talked about, the ones that are in production, CCDA, it's a document. It follows that document paradigm. Well, in operations, one of the things we want to do at the bottom of that middle row is we really want to figure out how we can make sure the data is part of the workflow. In this diagram, it's part of the workflow for providers. We've done an assessment and realized it works for the payer workflow too, and because it's not documents, it's at a lower level of granularity, FHIR can be integrated into the workflow real time. So with what we're trying to do with patients and value-based care, real time is extremely important. And last but not least, the far right column is who's engaged. Cerner, Epic. Jiten was one of the speakers that was talking about Commonwealth Alliance, and all the key EHR vendors that we as payers see in the field working with provider organizations, they're all represented at the table, working at the Connect-a-thon, working on FHIR. So we see that as an opportunity for a standard, and it's being used by many as the technology backbone for many of the health systems that we're working with. Let's talk about value-based care. And this is the Blue Cross definition where, because again, we've got 36 local plans across the country serving 107 million people, 1 out of 3 Americans in the entire country. Interesting statistic, value-based care, 1 out of 4 covered members of Blue Cross are in a value-based program right now. So and that's a growing percentage. So when we talk about value-based care, the center column there, we're talking about the value so we can get consistent value and measure that value, integrating that care. So the care coordinators from the payers, the care managers from the providers, and the caregivers for the member, all using technology to integrate it. And last but not least, it's about that customer flexibility, customer being as a plan, the employers, and for customers also being the covered employees. And it's also about transitioning healthcare. We're a big believer in the triple aim, and value-based care is part of that transition to the triple aim. What that means for us is important provider empowerment. Don't have the time to go through the whole list, but a couple of things. Actionable analytics and reporting. Major health systems, major payers are also doing massive analytics, but the value of the analytics is not too good if you get a report a week later or a month later. The capability and analytics to do it real time and use FHIR to actually, at point of care, make an impact is a pretty exciting opportunity that we see and are going to be operationalizing. Care management support, whether it's the nurse care manager for the payer or the case manager for the provider, technology and resources available to them is one of the things that will improve care. And last but not least, near the bottom, collaborative meetings. It's really important that we get away from phone calls, faxes, and actually use technology to empower, improve collaboration for all members of the care team. On the payer side, the provider side, the patient-centered medical home, the ACO, and the consumer. And let me talk just a little bit about the consumer. You'll see a link at the bottom of the page. I was part of a team with HealthWise. HealthWise is the source of the clinical data for WebMD. HealthWise as a company for several payers is the front end to the consumer. So we worked together at looking at a prototype for Adam Everyman, a person with chronic conditions, getting care from multiple providers, and a variety of people supporting them, payers, providers, population health managers. And we've learned, and the research is showing, that it's all about that patient interaction supporting improved outcomes, and we see a real important link to FHIR. As part of this, let me share with you what some of the health plans have done. At the very bottom, this is from HIMSS 15, and it's about North Carolina Health Plan. Healthogen, some of you may not realize that's a technology subsidiary of Aetna. And as always, when we get involved in chronic disease, maybe 50% of your population at the top left has chronic illness, but look at the bottom right. They're driving 76% of the cost. And yet chronic disease is something that can be impacted at point of care, and an engaged consumer, an engaged patient, it's important to do that as part of improving that number. And this is where FHIR can come in. Here's an example of alerts that can be driven by analytics. And with FHIR, you heard about Smart on FHIR, which is about smart-enabled APIs that Harvard's been working on for the basically the top gun tools to be outreach to the consumer. And what FHIR allows me to do with that resource in the middle and the gap identified with FHIR Analytics is send one alert to the doctor that's focused on his or her perspective, and then to the patient, a different alert that says, we think there's something that would justify in you calling your doctor. And depending on whether it's the ACO or the payer, the ability to know the attribution of who's that provider, so that as I ping out, I think you heard in presentations earlier, one of the challenges is sometimes the docs don't know that's their patient because they haven't seen them for 3 or 4 years. But because of the claims information we have as a payer, I know that's still your doctor. I can ping that doc, ping that consumer, and actually give them the name and phone number of where they're supposed to call. That's technically feasible. The trick is how you can do it in a standards-based way. In North Carolina, working with technology, what they did is improve 23 out of 28 measures. In the far right, 16% improvement in colon rectal screening, 70% approval in readmission reduction. I can tell you as a payer, those are numbers that really make us pay attention because we know how that affects the bottom line and we know how that affects improved care. So that's given you a little bit of the insight for why we're interested and how this relates to some of the initiatives the industry is trying to do with the triple aim. Let me talk about some of the use cases. Where do the payers see the value? And I'm going to do that from the context of 2 of the vendors that work very closely in the payer community and have participated in the payer summits and shared their perspective because they work with many of us in the field. I'm going to start with EdFX that works with both payers and providers. They put together a nice picture. You'll see to the left, you've got an ecosystem that has the patient and the member in the middle, patient-centered care, but around that ecosystem, you've got the hospital, the PCP, the health plan, the laboratory, those ecosystems tied together in a vision of the future that has FHIR. And here's the use cases from EdFX perspective in working with several blue and non-blue payers. Of course, we want to use FHIR to do a patient query, but with FHIR, it can be a real-time query against multiple databases to figure out who's got information on that patient. In Michigan, you have the HIE, but I'll tell you, outside of your state, I've got at least 2 blue plans where their HIE failed, either politically or technically, so they don't have someone to go to. But with FHIR, I could do a direct reach out to at least 2 of my top providers and get that query with FHIR in the FHIR-enabled future. Structured data capture is the FHIR capability to do questionnaires. I'm sure many of you who are on the provider side know that a variety of payers have forms they'd like you to fill out for their quality measures, lots of forms. Wouldn't it be nice if all the data that's electronic, instead of a smart PDF that you can fill out, how about if it was a FHIR-enabled query that went in, hit your EHR, the EHR automatically filled in every field that it knew because it was a data element, and sent it to the provider to say, hey, I've auto pre-filled this, do you agree? And then edit it and send it back to the payer. We're pretty excited about that possibility, and hopefully we'll be working on that in Baltimore. Patient scheduling. Imagine one of our nurses at a call center has got a patient. We've looked at the lab results that we have, and we realize, oh my gosh, we need to get you scheduled for appointment. Well, FHIR would allow me to do real-time queries out to all the providers who are in that network for that specialty. And while I'm on the phone with the patient, be able to say, here's the patient's, on your smartphone, I'll send you the locations, geo-address, these are the ones that are within 5 miles of you. No, that's not available right now, but it will be. It is feasible. The technology's there. And last but not least, finance. I'll have to admit, if you talked to me a year and a half ago, I was not one of the acolytes liking FHIR because I said, finance, we've got X12 and HIPAA. Why would I even think about using FHIR? There's no regulatory way to go there. Had a discussion a week ago and realized, there's actually an incredibly nice use case, which is for ACOs, patient-centered medical homes. Most of the payers have a claims database, and it's a longitudinal database of everything we know about that member. So if you're an ACO attributed member, wouldn't it be nice if I could trigger out to you all the claims-based data in FHIR? Well, for that to happen, I need to map all the 837 data elements to FHIR and make sure they're all there. we're working on it, and hopefully we'll be able to get that done by the July 24th deadline to get into that next ballot for FHIR. But that's one sample of the use cases. In terms of some of the key lessons, again, for the sake of time, let me focus on some key ones. At the top, coexisting. FHIR can coexist with V2 and with CDA. It can augment or replace, but I can coexist. So that's definitely something we're interested in. Trust, this is all about payers, providers, vendors working together in that value-based construct for the triple aim. And last but not least, validate at the very bottom. A variety of HIEs are setting up FHIR test boxes. All the major vendors have a way to get their FHIR reference server, so there's an opportunity to go out and start learning what this tool does and what the vendors have capable of doing in terms of working with FHIR. Nant Health, some may have known it as Navinet. To be clear, they used to be owned by Independence Blue Cross and Highmark, much like AmeriHealth Mercy Caritas, owned by Independence, one of the fourth largest blue plan. They're kind of familiar with things that we do in the payer world. I think you can see there's a lot of things that they've seen we could do. On the left are the things that are on the patient documentation side, clinical documentation, administrative documentation. On the right, things that are on the practice side, value-based contracts, HEDIS information, things about, and let me go to the left and make sure I've covered one of the EOB is one of the areas that's kind of interesting, because if any of you have received an EOB in the mail, that thing that's really thick with lots of pages that you can't get through, wouldn't it be nice to get that EOB presented to you in a smartphone format that you could use? Mark Scrimshire, raise your hand, I know you're typing. Mark is working with CMS. They're working on a multi-million member database and getting that thing converted to FHIR so that for the CMS beneficiaries, they're going to be using FHIR to make an EOB available. He'll be doing some more prototyping on that in Baltimore. So there are some big scale things underway. VA's already done 2 prototypes. I think because of their budget, it's like, I think 3 or 4 years before you'll see it, but they're already working on their 2nd generation of work with FHIR. On the far right, let me tie some of this work to stuff I'm doing and what Damien pointed out. Damien mentioned the variety of existing resources that are there, and Wayne talked about one of them in specific, data access framework, where they've mapped into the meaningful use 2 data elements. Let me explain how that actually links back into HEDIS. HEDIS and STARS, everybody familiar with STARS, know the STARS program? Yes, well, let me explain the financial implications of STARS. One of the largest payers in the country, who is not blue, missed out on $1.1 billion 2 years ago. And no, I meant $1 billion. They got 4 stars, couldn't close their HEDIS gaps, missed out on $1 billion. I can tell you that the VP and that team doesn't work at that company anymore, but they were kind of hamstrung in fairness. How do I get this data in an actionable way? I'm actually right now working with Optum, Cigna, Florida Blue, Independence, South Carolina, and Alabama Blue. And then I've got, as part of the work on the Connectathon and working with FHIR, Epic, Cerner, Allscripts, GE, and McKesson. We've been working for 3 months, informally, trying to look at how we can use HEDIS on FHIR. Clinical quality format on FHIR is a brand new language that HL7 has been working on for CDA. They've converted it to FHIR. We took a look at it and realized, wait a minute, if I match that with data access format and the vendors that are already porting out those 18 data fields, we can do some of the data elements for HEDIS. HEDIS, you mean that thing where I get the paper chart and type it in and then send it to NCQA? And the payer and the provider are both doing manual effort? I could do that with FHIR. That's why I've got such a big list of people, because that's a real interesting prospect. We're still working on it, still trying to make sure it can work, but it's something we're working on, and we'll be trying to move that ball forward in Baltimore to position ourselves for doing some pilots in the future. This is an example of a deep dive use case on FHIR. Independence Blue Cross has been looking at colon rectal cancer screening. So they went to their contractor, Nant Health, and said, we've seen this FHIR stuff. Can you see if it might help us with value-based care? This is a prototype, a working prototype that they built. Did not go into production, but literally in less than 4 weeks, built this entire system driven by FHIR APIs. This could have been built with regular APIs. Don't get me wrong, APIs work. But the issue is, for those of you who work with APIs, well, those are one-off builds. In FHIR, they were able to use existing resources and stand this thing up in less than 4 weeks. Let me explain how this tied to $500,000. Independence has reported this out at the FHIR User Group, FHIR Summit, and also at the Partners for Interoperability. And this is part of the report the chief architect gave to his C-suite. CEO, senior VPs, explaining why they thought FHIR helped. Number one, there's all these proprietary EHRs. You can talk about CDA, but they're all different. And in many cases in production, it's not CDA, it's a proprietary custom link to get the clinical data you want. The second is, for making some simple real-time requests for member data, FHIR is now the de facto standard to do that instead of having to build an API custom. Third bullet's about rework. When you build something changes, standard doesn't have it, oh my God, I gotta wait till the next year's release. Not in FHIR. FHIR allows extensions. So we can take it, add an extension, not a lot of significant rework. That's a big deal for production size environments for large scale payers, large scale providers. Last but not least, this is about future proofing. Value-based care is evolving, CMS is evolving in what they're doing. This appears to be an opportunity from a payer perspective to really make a change. How did that end up with $500,000? Real simple. That prototype that we talked about, colon rectal cancer, they were 3 weeks into that, and the chief architect found out that somebody had told senior management they could have something done by the spring, except he had been working off prototypes that they'd built, didn't realize the 6 prototypes didn't equate to the 80 that they needed to build for production. And we had 80, oh, I'll be done in December. And then the light bulb went off, wait a minute, I just built this colon rectal thing and I built it in 3 weeks. Okay, we're gonna do it. They are moving a production new SQL server for their interface out to their brand new state-of-the-art payer portal that integrates old and new databases, and they're running it with FHIR. And they're gonna make their deadline, and they did the math. They saved $500,000 by shifting from APIs to FHIR. Orion, who is here speaking, I think they show it on their screen, and their stack underneath that runs entire countries for clinical data exchange, parts of their stack are run by FHIR. FHIR is not necessarily going to work tomorrow interoperably because all the EHRs aren't in production yet, but it works. It means it will work in the future. So now's a good time to start planning for it. So let me do a quick wrap up with the big picture of where this goes and summarize what you can do, where you can go with this FHIR environment and what you can do with some links. This is something I shared with my enterprise architects from all 36 plans, so I figured it was good advice for them, it's good advice for you, and we'll get you in the right direction if you're new to this. This all comes back to Adam Everyman. What do you do to get that patient interaction up? What do you do to enable those people who are trying to provide care at the institution, at the payer, at the caregiver, to be able to provide that care? Here's all the pieces that are at the table. Everything from ADT to lab results, medication list, patient-centered medical homes as stakeholders, information exchanges like MiHIN that are here. Here's how you get it together at the big way. To improve that automation and standard exchange, we know on the left side, the payers are going to want to request provider data. We know on the right side, the providers are going to want to request payer data. And we've got CDA, but now we can also enhance that with FHIR. You've got a list of vendors that are involved in that on behalf of payers and providers. I am not trying to say these are the only vendors, but I am saying these are the vendors that are at HL7, are engaged, and are working with FHIR, and are planning to bring things out. For example, Epic is going to be rolling out across the system at Duke University their FHIR-enabled suite for their EHR. So this summer, Duke starts being able to figure out how to operationalize FHIR. I'm sure hoping I can get Blue Cross Blue Shield of North Carolina to be part of that party. We'll see. I think it's important to realize when you look at this diagram, realize I'm talking about learning FHIR now so that you're in a position to do pilots and prototypes next year, so that in 2018, when all of these EHR vendors have that product on the market, you're ready to engage and be part of that. Now, that doesn't mean, as you've seen from the 500,000 saved, you don't have to wait till next year. There are certain things that you can do this year, but to do that, you have to understand FHIR and what parts of FHIR are developed. As Wayne said, they have a number assigned, whether it's 0, 1, 2, or 3. Well, if it's a 2 or a 3, it's capable of being used if you understand that resource and its limitations and you've got a partner. This is like the fax machine. Who's first, who's second? If I got a fax and can find a partner with a fax, we're good to go. I don't have to wait for everybody else. Realize that paradigm really works well in this FHIR environment. Let me talk about what you can do. So partly is figuring out where your organization is with clinical data exchange. People say the word. I'm talking peel back the onion. Where are they really with clinical data exchange? Second, your EDI administrative people, the people that do claims, they can move data all day, all night, except they're used to administrative data. Are those people pivoting? Is someone in that group pivoting to clinical data? Hopefully they already are, or in some organizations, they've kept them separate. They got admin guys and claims, and they got a separate group. I know for many of the payers, they're just adding that as a new load to their EDI guys, and most of the EDI guys are okay with that, as long as they can get access to the training and aren't just thrown into the water. In terms of where you can start looking at those FHIR use cases. In the appendix for my slides is details on those FHIR use cases and hot links. Yeah, Wayne, my links are PDF, but they actually work. You'll be able to click on the hot links to actually go to, I didn't list all the tracks, but the ones that I thought were applicable from a value-based care perspective, click on those. You can go look at the use case track and what that was intended to do. In terms of education, I've got 3 links that'll take you to the FHIR overview. One of the FHIR vendor, one of the active users in HL7, CorePoint, has a really nice 30-minute video clip on all about FHIR and all about the HL7 standards. And I found a really cool YouTube video of a vendor. I don't know who they are, but he's really knowledgeable, and it's a really nice 4-minute clip that you can look at as a refresher and you can share with your managers and they won't get blown away. It's nice as a good overview of what's FHIR and why should they care. And then come to Baltimore. There's going to be a connect-a-thon. There's going to be some meetings. I would encourage you, since Baltimore is not that far, great place to visit, to come. And last but not least, let's not forget ONC. They're doing things on blogs. They've got a brand new tech lab that, again, is more information that's in my appendix that I encourage you to look at. And let me just quickly show you what ONC is doing. They've got a proving ground, and I think I can read from here 219 examples of the projects that are going on in interoperability in the industry, background on the project and who's doing it, and hopefully some of you will be doing some projects that get put into this. I know I'm working on some and hope they'll be there. They also have some new funding announcements, the HIP and the C. Everything's got to have an acronym. HIP's $1.25 million. 5 or 6 people are going to get some money to pilot and move things forward. They'd really love to see some FHIR initiatives in this. C is $250,000, and that's for small researchers who want to research some piece of moving healthcare interoperability forward and getting a little bit of money to help them move that forward. Again, this literally just came out in May, so these things are hot. There's, again, in my appendix, I've got detailed descriptions on these programs and what they do. I've got like maybe 1 minute for questions. I'm sorry I didn't leave more time, but I covered a lot of territory, but I'm real good at answering really fast, so yes, sir.
Yeah. What effect do you think FHIR will have on the CAQH core requirements that they're developing for the standard operating rules and vice versa?
Now, are you talking about the operating requirements or for quality reporting?
The operating requirements.
I'm sure I asked this nicely. What I can say is NCVHS issued their letter for this draft for the secretary this week, and in that letter they are saying for the new core operating rules that they want those to be voluntary, because they believe those operating rules are based on standards that aren't yet used because they haven't been named, so they can be used, but people are realizing, geez, I haven't even used CDA in production short of meaningful use 3. That's not the same as HIPAA that affects everybody, so it's a little premature is kind of the official position NCVHS is taking. I guess maybe room for one last question. That was a good one, thank you. Hearing none, we're good, thank you.